Hi, everybody. I'm Ian Johnson. I think you all know that. I just wanted to say hi anyway. And I want to thank you first off for being a preceptor and supervisor for the residents doing the public health systems of practice rotation. The purpose of this short video is to give you a bit of background information. So let me start by showing you a bit of the agenda and what I have for the agenda for this afternoon's session here. So as you can see, the first thing I'll do is say thank you. The second thing I want to do is talk to you about why the purpose of the rotation and why we changed the rotation. So the purpose of it is basically to ease the transition of the residents from clinical practice, because really they've been in clinical practice for the last 2 years as part of family medicine. And in some cases 3, because they've taken extra time. And it's to ease them back into public health practice because they've really been out of it for the last 2 years. They've been to a few rounds, but we really can't count on them as being part of that. In some cases, they're going on to graduate work. In some cases, one case this year, they're going straight on into their field rotations. The second purpose is to do a bit of career exploration. So feel free to tell them why you went into the current job, what you went into with PHPM, why you're doing this, because I think it helps them understand what are the career opportunities, and then they're planning their rotations for PGY 3, 4, and 5. It really helps them to understand where things are going. Why did we make this change? Well, one is obviously resident attrition, but I would say because we lost a whole lot of students during this transition, or residents rather, during this transitional time. But certainly when we had meetings with the exit interviews with residents who had just completed the program, there was a universal comment that the transition from clinical to public health was actually very challenging for them. And a lot of residents who were going on to become fantastic PHPM specialists said they had actual doubts as to how well they were doing. And they needed to have this time to help them understand what was going on. And we want to help them to get back into public health thinking. Been in the clinical mode, so we got to flip them back. So what have we done? Well, it used to be just in local public health units, and now there's part in the federal government, provincial government, and as well within the local public health system. I would say the focus is more on the collaborator, working with staff. So there's a heavy emphasis on the collaborator, like yes, the medical expert understanding the system, because you could put that as manager leader also, is important. But I'd say collaborator is really important to get them to know who the staff are in a public health unit, how they work, how we work across different organizations. So what's in a local jurisdiction, what's in a provincial, what's in the federal jurisdiction. There's also a focus on Indigenous health. And Ani's going to speak later more about that, but we're trying to move that to be more in the curriculum. We want to enhance some basic skills, such as how to set up agendas for meetings, how to run a meeting, how to take minutes, how to do consultations. So working on these basic skills. It's not a big part, but we'd like it to be part of that. And obviously reviewing some basic public health theories. We've given them a series of readings. They're all available on Quercus. So if you have any questions, please go to Quercus and you can talk to that. If you need access to Quercus, please contact Katrina. In fact, Quercus is really the main place, and I would recommend that you go there. I'm going to send out copies of all of the learning objectives and their suggested activities, but I think it's good for you to go to Quercus and also see all this stuff, because that's what the residents use now for all their rotation. So let's move on. I'm on item number 3 here, if you're looking at the screen, to look at what's the role. So there are going to be visits with the Public Health Agency of Canada. Dr. Rob Sterling is our lead. So when the residents are on the rotation with the on their days at the Public Health Agency of Canada, Rob is basically their supervisor. So if you're working in a local public health unit or you're at the provincial level, basically don't worry about it. Rob will look after that. They're going to have an orientation to the Public Health Agency of Canada. It's probably going to be virtual this year. They're going to look at Indigenous health services, and they're going to go to such topics as the Quarantine Act, the International Health Regulations, these kind of things that the federal government covers, things like the airport, this kind of stuff. So Rob last year organized a visit. So the residents went out and visited Pearson Airport and the Canadian Border Services. I have no idea if that's going to be possible. We may look at that in August if it's at all possible, but right now there's no plans for it. And they're going to spend time with the Ministry of Health. And for this, Dr. Daniel Wachowski is the main lead. So Daniel will be looking after all of that. They'll then spend some time at PHO with Leanne McDonald. So Leanne is the leader for that. And then they'll be visiting the local public health units. So 2 are going to York and 3 are going to Peel. And we've already sent out the messages on those ones. Many of the sessions are going to be virtual in July, and I'll show you the schedule in a few minutes. But basically, they're going to be virtual. And but what we've tried to do is also create some case studies. One is on tuberculosis, the other is on hepatitis A. And we're trying to show the collaboration across the different areas. So part of that's going to be local, but some that's going to involve provincial, some that's going to involve federal. And we're trying to use these case studies as a way of showing the integration across. We recommend that you take up the case studies with the residents. They should be working on them. They should work on them probably in the month of July. So probably I'd recommend you be familiar with them. And then later on, we work towards the final answer on all of these ones, or at least take up the answer probably at the end of July, 3rd week of July or so. Take up the answers and have them present on it. During the summer, Academic Half Day on Friday mornings is going to cover basic topics related to this field. So for example, we're trying to get a session on the organization and structure of public health, another one on governance. So we're trying to cover the academic topics for this rotation. During the Academic Half Days, you're more than welcome to attend if you have time and if it's possible for you. For the local public health units, we are recommending you do an orientation in July. We're going to give you, their residents are going to be there for 2 days. So they're going to be with the Ministry of Health and the Public Health Agency of Canada and PHO for Mondays and Tuesdays. They're going to be with the health units Wednesdays and Thursdays, and they're going to be Fridays back at U of T working on various things. But we recommend in July that you provide an orientation. We realize you're still going to be heavily into COVID and probably reassessing. Looks like some people are coming out of IMS in the middle of July, so we'll look during the transition. It might be a good time to give them an orientation to what goes on in the health unit. And then in August, we'd like you to move on to more of the non-COVID, where hopefully we'll be back into other services. So give them an orientation to what is healthy environment, what is healthy growth and development, etc., all the other communicable disease control, all the other areas. With regards to the projects, we suggest you have multiple small consultations in different areas rather than a major project, as the focus of this is on learning the various structures. Having small projects in particular topics may be would be a better way of going at this. We also want to teach residents how to do consultations concisely. So how to formulate questions, how to think quickly about getting answers, and getting answers in a relatively quick time. Like, you don't have to have everything perfectly. We're not expecting a full lit review, but say, can they, you assign them something on, this is in August, but say you assign something on a Monday morning, can they come back with an answer by Wednesday afternoon, so you can take it up on Thursday? Like, these are the kind of things to look at where they have to do a quick consultation and really dive deep and get to this.
Hi, Ani here. So I am doing the section on the ITERs, so doing the evaluations and the Indigenous health content. For overall summative resident assessment, which we previously called evaluation, so like the ITER, which is being converted to the ITAR, for E being looped out from evaluation being looped out for assessment. The point is, you will be responsible for the main evaluation on power as the supervisor. But we'd like you to obtain feedback from stakeholders at your site. So anybody who worked with the resident that you think is relevant, which likely you're used to always doing. Because FISP is a little bit different with the different site visits and that type of thing, Ian will send out an email to the site visit leads, like at PHO and PHAC and things like that. And he'll just ask for information about any like outlier situations. So if somebody was like particularly stood out for good or bad reasons, then he will connect with you. But otherwise, no news means, everybody was pretty much, within expected. So that part won't necessarily be in the ITER. For the rotation and to help guide the assessment before you get to the point of the ITER, I strongly recommend looking at the rotations expectation document, which will be sent out, the rotation specific learning plan, which has the outline for the ITER, and the resources document. That's what the residents have been referred to as far as their readings. This becomes particularly important because right now their work will be more focused on COVID-19 than usual, or on communicable disease. So this is just a reminder about the rotation specific learning plan. As you can see, there's the World College objectives on the left column, the ITER field, so you know which pieces directly will be assessed in the ITER, and then recommended activities. Some pieces we think that residents should learn, but isn't necessarily an ITER piece because there's more to life and learning than the ITER. We also recognize, because of COVID-19, that you may not be able to fulfill quite a few of these, but it still makes sense to keep it in mind in case some opportunities for more diverse learning opportunities come up. With regards to the Indigenous health section, so we're going to take care of that centrally, but of course, if there's opportunities for Indigenous learning at your site, please engage the residents. They will be taking the Sanya's Indigenous Cultural Safety online course, which is really focused on clinicians, but has a lot of general learnings that are relevant for resident learning. So it's an 8-hour course that takes place over 6 weeks. It's self-directed, and they will have time for reflection. So they will have time for this on Friday afternoons after rounds. And we're trying to arrange some contact with federal leaders with regards to Indigenous health, but overall it's part of our indigenization of the curriculum. So there are more and more opportunities for residents, and we're trying to create more opportunities for residents to learn about Indigenous health beyond that cultural safety course and beyond FISP. But where you can enrich their learning through your colleagues, that is great. All right, that's it for my section. And thank you again for having our residents learn with you in the public health systems and practice rotation.
Hi, everyone. Thank you again for agreeing to supervise our residents during their public health systems and practice rotation. As Ian noted, and I'm going to go over a little bit again, we've changed things up. We really appreciate that you're willing to supervise them. It's going to be a little bit of an unusual rotation, and I just finished an orientation of the residents where I made it clear to them that things are going to be, they'll need to be flexible. Everyone's going to need to be a bit flexible during this rotation, but there are 5 of them total. And so I think both as individuals and collectively that they'll be able to contribute to the operations of the health unit, as well as, to the well-being of people in your health unit, and hopefully learn something as well. Although education certainly is the primary goal from their perspective, but I know there's a careful balance of education and service always, and it tends to be a 90 education and 20 and 10 service, and hopefully, they see it in a positive light with respect to that balance as well as you. So I'm going to go through a couple of slides, both about their expectations and mostly about the assessment piece. I just oriented the residents. So this is the resident orientation presentation. And as Ian outlined, there are 3 big chunks to this rotation: introducing the residents to public health systems, the context and the content, and to the work environment, the culture, the principles, the documents, and all the people, as well as transitioning to public health practice, which is very different than clinical practice. And, there's all those tensions of just not seeing individual patients, long-term goals. It really bounces them back down to being what amounts to kind of observers in 2nd or 3rd year medical school in some ways. And it's tough to empower them because you don't know them yet and how to engage them appropriate for their level, and of course, career exploration. So there have been lots of changes. They're going to FACT, they're going to the ministry, they're going to PHO. They're going to be going to you for July and August, well, for it to be the base for their rotation. Mostly in July, they'll have these other things that they'll be doing. And in August, hopefully we'll be back to more normal-ish operations by then. And there'll be an Indigenous health piece. So in terms of the assessment, which is the main thing I wanted to talk about, there's going to be an ITER. It's different than previous ones, but, it's a regular old ITER that's a little bit tighter, hopefully. I've made it clear to them that they really need to be reviewing the ITER beforehand, all of the materials, and in a nice way. Hopefully you can just continue to re-emphasize that. We want to set, a really nice high bar for them in terms of both being responsible for their own learning, also organizing some of the logistics of their own learning, which I'll talk about in a minute, and actually reading all the documents or at least having the chapter titles familiar to them. I try to push them a little bit. They don't have to know everything in the Milk Act, but they have to know it exists. Some of them have just heard of the Ontario Public Health Standards, and expect them to look through that as well. So the other bits around assessment. So SBARCs is something I think everybody is familiar with a little bit, because I've been yibber-yabbering about them for some time. And I find they're really helpful. I've been using them, in my work for quite some time. But really from London, 2 or 3 jobs ago, I found that they really made my life a lot easier, because they came to me with a concise description of the situation in the background, a real assessment, which I can either judge from the managers whether that's legit or not, and the recommendations, which if they look good, you just say, go ahead with this. It's very clear and easy to use. So I don't know how many of you are using them in your practice, but I find it really helpful. So I really want to get the residents into it, because it's also a great way, just like in their clinical training, if they haven't got the assessment right, they're not going to have the treatment right, or the recommendations in this case. And it's a really easy way just to judge, whether they're up to par, how you can help them get where they need to be, and even to complete the evaluation. So we're going to encourage them strongly to use SBARCs in their work, maybe just 1 a week or 2 a week or something like that. And you can use those as a point of discussion with them if you feel like it. What we're planning on doing is also having them write some reflective notes. We haven't settled on the format yet, but a reflective note, I observed this, I felt this, my feedback was, would be this. And Ian and I are going to take turns, I think, every other Friday reviewing the SBARC. So you can review them individually or in your group of 3 or 2, depending on whether you're York or Peel. But either way, I'm going to make sure that they've done some, sent them to me. I'm going to review them, whether it's in a half-hour session with them or something like that every other Friday, or maybe even every Friday. We'll see how that works. So, that's a piece of the assessment that and the teaching really that Ian and I are hopefully going to take that off some of your plate, because, we're all very busy. There's going to be project work. Obviously we've hopefully, like a consulting level kind of thing, or, you guys are all familiar with what a project looks like for a PGY, 2/3. Most of these folks, or all of them, are really quite competent, and they've worked, in COVID as an elective in their past couple of months, with the exception of one of our residents who's also very strong, but she's skipped the 3rd year. They're hopefully going to be contributing, and they'll be judged on that work. So that's the project work. We're hoping to have you meet with them. I've set the expectations nice and low, because even though, it'd be nice if there was more. If you are able to give more, then that's great, and they'll be appreciative. If we tell them the supervisors are going to meet for 2 hours with them, and then it's only an hour, then they're upset. If we say 15 minutes, it ends up being 30 minutes, everybody's happy, So that's the expectation that I've suggested to them. And what I've also told them is, come to those meetings with an agenda, even if it's just, review what I did, provide some feedback, chit chat, like, come with an agenda to that meeting, and maybe even provide some minutes to that meeting, getting them into the mode and setting the bar pretty high. I just want to let you know what our expectations of them. And it is my sort of approach that I like to set, a good high bar and then try to move them towards it, but not certainly just be disappointed if they don't meet it. But, I've been clear with them, as they're joining now, that if they haven't heard of OPHS or the HPPA, which now all of them have because I oriented them to it, that they don't have to have it memorized, but they got to be reading the organizational strategic plans and publications and being familiar with the key documents. And so if you can help them by mentioning a document and then, having a reasonable expectation that they might, engage with it or even come back to you with a little summary of a piece of it or something like that, wouldn't be unreasonable. I've made it clear to them that they're to read around cases as well. It's not a full literature review or a scoping review or something like that, but they know how to do these things, and we've said that we expect them to do that. I've of course asked them, as I mentioned before, to be flexible and reasonable around expectations of supervisors and staff, and I've been very clear to them that you might not have all the answer to the question. I mean, I'm as you know, MOH appeal, and I don't necessarily know all the elements of the org chart right now and where we're sitting. I know that it exists, and I've told them that even some of those people no longer work there, even in the past couple of months that I've been there. So, we'll provide them an org chart and we'll encourage them to ask questions about it, but to have reasonable expectations of what they might know. And what I've also told them is that sometimes even any of us are going to have answers to some of their questions, particularly about the organization of the COVID response. And I've actually asked them, and hopefully I'm going to really, do this in a concerted way and an organized way with them. But given that they're moving through different pieces of the Ontario public health system, that when they're at, when they're at the ministry, when they're at FAC, when they are in the CMOH office, when they're with us, that they actually be, documenting, recording, and speaking about, who's doing what, who those partners are, and who those people are accountable to. And they could actually, I've told them they can meaningfully contribute to our understanding of how our response is going in Ontario by, recording some of this information and sharing it. So, that's going to be an expectation from me, at least over the course of their 8 weeks. How formal that is, it remains to be seen. I also mentioned to them that, supervisors don't get paid, and time taken away from their families and staff and clients and work that is not going to go away is important. I didn't overemphasize this and made it as a sort of a parenthetical bit, but to also respect that you have different pulls on your time at all times, but especially right now. And I also help them to recognize that many of our staff and MOHs have been working full tilt for a good 100 days now. And it's not easy for everybody. In terms of feedback, I know all of you are terrific at giving feedback and doing it regularly. My one ask would be, just when you're giving feedback, let the residents know you're giving feedbacks, because it's just really important that they recognize that that's what it is, so that sometimes it's done informally, and we certainly think we're giving feedback, but it's just really important that they know what that is, and it's not a casual conversation, that you're trying to give some supportive or constructive feedback to them. So just to highlight that that's what it is, or maybe even just as I've told them, 15, 20 minutes, set an agenda with your supervisor, and always have that feedback piece on the agenda. And then, the sandwiching the negative in between two positives and all that good stuff. So thank you again for doing this. Very much appreciated, and hopefully it's a good experience for you as well as for the residents. Have a great weekend, and I'll see most of you very shortly.
What you're seeing on the screen now is the public health systems and practice schedule that has been circulated to all of our field sites. The public health systems and practice rotation is scheduled for blocks 1 and 2, or from July 1st until August 21st, 2020. During that first week, you'll note that it's Canada Day, and there are a number of program events that are scheduled for that week, including the resident orientation. So the FISP schedule will actually not commence until Monday, July 6th. So as you can see in those first few weeks, there is time allocated for the FISP residents at PHAC and PHO on Mondays, and the Ministry of Health on Tuesdays. On Wednesdays and Thursdays, the residents are back at the local public health units, and on Friday, it's a combination of academic half-day in the morning, as well as individual and group learning and reflection in the afternoons on Fridays. On the right-hand side of the table, you'll notice that there are possible weekly themes that have been suggested. The schedule is relatively open-ended from late July onwards, so you can use these suggestions or continue having the residents do consultations at the local public health unit or working on mini projects.